Welcome aboard.
Please welcome to the stage Axios senior healthcare reporter, Tina Reed.
Good morning, everyone. Thank you so much for getting up bright and early with us this morning in this beautiful rainy day. I am Tina Reed. I am the author of the Vitals newsletter, and I'm excited to be here this morning with you with some great guests to talk about advancing our understanding of aging in the brain. To those tuning in online, be sure to use the hashtag Axios Events. So without further ado, I'd like to welcome our first guest, a longtime advocate and leader in brain health. Please welcome to the Axios stage, Us Against Alzheimer's co-founder and chairman, George Vredenberg. Well, thank you so much for being here with us today.
Delighted.
Well, I wanted to start with a little bit of an intro into your organization, which you started with your wife, Trish. Can you talk a little bit about why you decided to start the organization?
3 generations of people of my family lost to Alzheimer's or dementia, various different forms of it. A grandmother in the late 70s of what was called then senility, because they didn't have a name for the disease. Then a mother-in-law in the early 90s with what was diagnosed as Alzheimer's, but it was clearly Lewy bodies because she had a lot of behavioral disorders. And then in the last week or so, a brother who died of a form of the disease, although I think congestive heart failure got to him first. So, but it was a race. So 3 generations of family. And I formed it with John Dwyer and Merrill Comer. John Dwyer, big Catholic family, 3 generations lost to Alzheimer's of different kinds. And Merrill Comer, who for 24 years was a caregiver at home for her husband, and then 10 years overlapped at home with her mother. So these are 3 families that basically had been deeply affected personally by the disease, and we had not seen much movement, at least when we formed the organization in 2010. And we started off as a political organization, a PAC and a C4.
You started it with a pretty ambitious goal, which was to essentially end Alzheimer's by 2020. Obviously, we're still dealing with the disease. How has your goal changed?
The goal has not changed. The end goal, the time frame has changed a bit. We now have 2 disease-modifying drugs that have been approved here, Japan, China, and a number of other countries. Europe has initially said no. So we have some real work just to get those through the pipeline. But the FDA's decision to use accelerated approval actually stimulated an enormous addition to the investment in the field. So a number of pharmas who had gotten out of the field of Alzheimer's are back in. A number of biotechs now rejuvenated with additional capital. So there's movement, but for patients, not fast enough, ever.
How has the approval of these anti-amyloid drugs changed our understanding of dementia, and do you believe we're headed in the right direction by going after amyloid plaques?
Directionally, after Dr. Alzheimer's identified this disease in 1906, 117 years to get to the first. So in a sense, this is like exciting, and on the other sense, it is just the beginning. What we believe is the sequence of the pathology of amyloid plaques, then tau tangles, and then inflammation, I think is just proving to be a sliver of the problem. Because we're finding in African Americans in the United States and Latinos, there's a different mix of the pathologies, more vascular dementia, more other kinds of dementia that's mixed with Alzheimer's. And overseas, I just got back from a 3-day conference we put on in Nairobi, Kenya, with African researchers. There's very little amyloid in the brains of those with dementia in Africa. So we don't yet really understand how much of this is amyloid and tau. It is something. It does have an effect. There is a clinical benefit. There are some risks, but some clinical benefits. So it's something, but it's not the whole.
Okay, so how does that sort of change, when we think about innovation in this space and what to chase after, how does that sort of change our approach?
It changes our approach by saying we don't need some blood-based biomarkers for not just amyloid, not just tau, not just inflammation, but for other forms of pathology, whether it's alpha-synuclein or other pathologies, so that when someone comes in for a clinical trial, eventually in the clinic, we can discern what is the mix of pathologies those individuals have and whether they're appropriate for a clinical trial or whether they're appropriate for the medicines that are on market. The current ones, as you mentioned, are amyloid targeting, but that's not the full story. But the next range is whether or not these amyloid targeting drugs, which are having a clinical benefit, whether they will work even better by going to people who have the pathology of the disease before they get symptoms. Because this disease starts 20 years plus before you get symptoms. So if we could interrupt and slow down this disease starting earlier in that course, we will have potentially a greater impact on the prevention and ultimate treatment of the disease.
How many, do we have blood biomarker do we have blood biomarker tests on the market right now, and what is the status of expanding?
There are blood biomarkers, largely laboratory-developed tests, which are appropriately used in the clinic today, certainly in research purposes. Some of them are quite good and equivalent to PET scans, equivalent to these big, expensive, and inaccessible scanning equipment, which we've been traditionally using. But some of them are as good as, if even not better, than that. Others are not so good. So one of the problems we are sorting out right now through one of our organizations is what is the relative validation of these different blood tests, how do they rank, and how should they be used? Should they just be used by neurologists, or can we begin to get primary care physicians to use these earlier in the course of the diagnostic process so that we can understand who should get these medicines that are targeted at the early stage of the disease, earlier in the course of the disease?
When we spoke before, you'd mentioned there's possible vaccines in the works right now. What is the status of the future of vaccines in Alzheimer's?
Well, I am bullish on this. We've had a task force now for about a year and a half, with 8 companies that have vaccines, active immunotherapies in clinical development. Now, most of them are going into stage 2 clinical trials. And so far, they have proven that you can stimulate your own immune system to attack amyloid or tau. Again, whether that's enough and whether we need other targets for those vaccines, we'll see. But I think the timeline for a vaccine, if all the science proves out, we work not only with 8 companies, but we'll work with all the regulators from around the world sitting in the same conference call, right? To say, okay, what is the science telling us? Regulators are saying, what do I need in order to approve a vaccine? Obviously, there's a great concern when you stimulate the innate immune system about whether or not you can ever turn that off. So you got to have a really safe product here. And so these trials will be probably very large in order to test safety.
I'm curious about your thoughts about GLP-1s, which are the class of medications that have been getting so much buzz for treating diabetes and obesity. There's been some early research that perhaps that might impact Alzheimer's, which has been referred to as type 3 diabetes at times. What are your thoughts about it?
Well, the public health literature is suggesting that this disease is the result of a variety of risk factors. Lancet's published things, and now 14 risk factors, most of which start in midlife, some very early. If you think about your own brain development, your brain starts working in the first year of your life. So this is a problem of what happens during the course of your life. Discrimination, lack of education, a variety of mental illness in your teens or 20s. All those things are risk factors for getting late life dementia. So the GLP-1s, which target all the cardiometabolic conditions, really should be used in midlife to reduce the risk of late life. So we think of this as an older disease. It's not. It starts in midlife to develop the pathology of the disease. And so cardiometabolic interventions, GLP-1s, will be very important. I personally think that low and middle income countries who are likely never to get the PET scanning equipment or the primary care system to diagnose this disease should be developing and overweighting on GLP-1s today. Because if Latin America, heart disease is the number 1 killer, dementia is the number 3 killer. If you can stop or reduce hypertension in midlife, you will be able to reduce the future impact of dementia. So we are working with PAHO, and in Africa, we'll be working with the World Health Organization's efforts there, basically to try and get cardiometabolic interventions in midlife in order to reduce the prevalence of later life dementia.
Nearly 7 million Americans are living with Alzheimer's today, and by 2050, that number is projected to jump to nearly 13 million. How prepared is the U.S. to handle those kind of numbers?
It's not. Our health system is clunky. That's not fair. Our health system is not used to dealing with these kinds of brain diseases at scale. So we're not ready. I'm going to contest the numbers, though.
Okay.
Those numbers are people with full-blown dementia. The people, if you take the people with pathology of the disease, it's closer to 40 to 50 million in America today because of the long lead time. We don't say, do you have cancer? Is this metastasized cancer? We count people with cancer once you've been able to detect it. So if you look at the real numbers of people with the pathology, it's closer to 45 to 50 million in the United States today.
That's alarming.
Not 7 to 10. Those are people on course, high risk of actually turning symptomatic. So we have to get this disease at stage 1 of Alzheimer's, not stage 4. And that's the goal of going earlier and eventually to a vaccine.
What should we be thinking about when we think about these very alarming numbers? What do we need to be doing more of as a society to take better care of our brains?
Well, I will tell you, we are about to announce tomorrow a business collaborative for brain health tool that businesses can use. We spend a third of our life, you're spending your life today as a business person in the private sector. It turns out that business is experiencing a lot of stress in the workforce, a lot of mental illness in the workforce, and in fact, those stressors are risk factors for dementia. And so we are now talking to business, creating a business collaborative on this that basically says business ought to get involved. This is a whole of society problem. It's not a government problem. It's not just research money, which it is, but it's also a whole of a society problem. So it's people at home, it's people at work. Business is talking to us about their increased perception that socialization at work, having a best friend at work, is a real stress reducer. So you want to go to work to see your friend. But they're also now encouraging their employees to get involved in community activities because they have sensed, and the support from research tells us, that social connections, intimate relationships with a spouse, family, but also friends, is the best predictor of good health and stress reduction. So brain resilience, not just the absence of disease, but brain resilience is now a business strategy, and we are going to bring the business community into this. And so we'll announce tomorrow a tool that basically will enable business to measure the levels of stress and the levels of resilience in their workforce and to take action in the workforce to produce a more productive workforce and more productive companies.
Does it also suggest, for instance, like coverage for hearing aids? I know that's been tied to...
Hearing aids is like the number 2 or 3 factor in risk reduction.
Yeah.
Education's number 1. That starts obviously earlier than midlife. So education is number 1, discrimination. Other stressors in life are in fact risk factors. But hearing loss or impairment is right up there at the top of the risk factors for late life dementia.
You've mentioned discrimination a couple of times and early life stressors. How did those contribute to our brain health? or the deterioration of?
Well, because your coping skills and with the stresses in life is one of the brain resilience factors that enables you to be able to resist this disease. And so discrimination, there are differences in the way this disease works in genders. There's different ways this disease works in African Americans, Latino Americans, than white Americans. We've only studied this disease in white Americans, really, and 80% of the genetic research in the world is done in white Caucasians, and 80% of the people with the disease are not white Caucasians, which is pretty stupid if you really think about it. But there seems to be other factors, social determinants of health, whether it's poverty, whether it's the stressors of discrimination. Those factors do put stress on your brain and disable your brain to some extent to resist disease. So if we can overcome some of these social factors, networks of friends, families, supports to reduce stressors in life, we will have an impact on late life dementia because your brains will be smarter. Indeed, in Africa, where they have a huge problem of youth unemployment, one of the theses they are pursuing is whether or not one can identify biomarkers or of both biological character and of social character in young teens to determine who has got a more resilient brain and better coping skills, and then develop potential therapeutic interventions and or social interventions which will enable younger youth to have better coping skills through their life. And so this is the whole notion of brain resilience is now got a major independent thrust than the suppression of the disease. So our brains turn out to be pretty important to the rest of our body and to our long, healthy lives. Well, the Harvard study, started in 1946 of both Harvard College graduates as well as lower economic elements of the Boston community, followed people for 80 years. The one single dominant element that predicted a long and healthy life was the quality and quantity of your social relationships. So this notion of a social impact of the disease is important. So lower income populations, rural populations, more adversely affected because they have more stressors and fewer resilience factors.
Well, that seems like a great place to wrap up. Thank you so much for taking the time today.
It's good to see you all.
Introducing our View from the Top moderator, Eugene Scott.
Good morning, everyone. I'm so glad that you are joining us, and we want to keep this conversation going with a View from the Top session where we're going to speak with some of our sponsors from this event. For this event, should I say, we want to give a big thank you to the Heart of the Solution for making today's event possible. And so I'm excited to bring to the stage the co-chairs for the Heart of the Solution, Mary Richards, and scientific advisor, Dr. Jack Juni. So good to see you. Thanks for joining us. Thank you so much. So glad we get to talk about this very important issue and that you'll be able to provide some insight to us and our crowd on topics that they care about most related to it. We know Alzheimer's has a profound impact not only on patients, but on caregivers and society as a whole. Can you share your perspective on the toll that Alzheimer's takes and the challenges that families and communities face?
Alzheimer's is not just a personal a disease that affects people and individuals and their families. It also affects us globally. In terms of families, there are pressures that happen not only for the person living with the disease, challenges in getting early diagnosis and interventions and treatments, challenges around cognition, memory, mood, behavior, and all sorts of quality of life factors. It also impacts the caregiver in terms of not only the challenges and stresses of managing a disease at home that affects the whole family, but also in terms of health measures, loneliness and isolation, and some other real challenges. In the US alone, there's 7 million people living with Alzheimer's disease, 11 million unpaid caregivers. And so when we think about numbers that are that significant, we also look at the economic costs of the disease to our society. It's $360 billion in costs this year alone in the United States. Globally, it's more than $1 trillion already. And we know that that trajectory, without something to really change the shape of disease, will only continue to burden families and our economy. It's on an optimistic side of this. The national government in the United States has chosen back in 2011 to make Alzheimer's a national priority through the National Alzheimer's Project Act, which is up for reauthorization this year. And that act created a plan to help to solve these challenging problems in Alzheimer's across all domains. So care, research, interventions, better supports and services. And we are thankful. We've got a speaker later today from the Department of Health and Human Services that is running this project. All different government NGOs and others are participating in that National Alzheimer's Plan. And so we're entering an era of great hope. It's been about 10 years, and we are seeing some significant ramping up in both investment and research, but also in collaboration and outcomes.
Awesome. I want to talk a bit about the complexity of Alzheimer's. We know it's a disease that is impacted by other health issues, and addressing them makes it very difficult at the same time for many healthcare providers. Dr. Juni, I would love for you to weigh in on the effect that blood vessels contribute to diseases like Alzheimer's and other forms of dementia.
Sure. The contribution is actually quite a bit. If you look at people with Alzheimer's, 80 to 90% have blood vessel abnormalities if you look for them, which is extraordinary and not likely to be just random chance. There are many factors involved. You hear about vascular factors, inflammation, the buildup of amyloid protein and tau protein in particular. It's important to not get overwhelmed by all the things going on. In fact, they all influence each other. If you have the buildup of amyloid protein, it actually causes the blood vessels in the brain to clamp down and reduce blood flow. If you have reduced blood flow, it causes the brain cells to produce amyloid protein, and it causes the amyloid to not be able to wash out if there's not enough blood to clear it. Amyloid causes inflammation and other related problems. So it can be overwhelming if you think of all these things happening, where do you go first? But in fact, they're all likely related. And what I think has been an area that's really coming to fore now is looking at the vascular components. And like I said, 80 to 90% of people with Alzheimer's have blood vessel abnormalities, and it ties in to this whole cycle.
Specifically, we've been hearing about the importance of taking care of your heart. Can you talk a bit about how doing that could reduce the risk of Alzheimer's and dementia and other memory-related illnesses?
Sure, it definitely does. There's good evidence that exercise, the heart-healthy diet, taking care of high blood pressure, all of those things reduce the incidence of Alzheimer's and probably reduce the severity. But if you total together perfect prevention program, getting rid of all known risk factors, you only have a 40% reduction in Alzheimer's. So we can't really prevent our way out of it. We would like to, we can help it with prevention, but we can't prevent our way out. So we need ways beyond that to affect, for example, the blood vessels. And there's a lot of research going on drug methods, mechanical methods, other things to open up the blood vessels and increase the blood vessels' ability to wash out amyloid proteins, and also to stay open and respond to the demand of the brain. Our brain needs different amounts of blood when we're doing different things. Listening to this, we need a lot of blood flow to our brain.
Okay.
Sleeping, not so much. So we need development of methods that address this from a variety of different approaches. And also, of course, to address other things like inflammation, eyesight, hearing, things like that. But the blood vessels is something that's really coming to the fore as a commonality between the different factors.
Has there been any progress in creating therapies for older people or people with disabilities related to like exercising and being active? There's been some research that really is helpful in terms of like responding to Alzheimer's, or at least preventing the risk of Alzheimer's.
There's a lot of data that shows, the Lancet just came out with, the commission just came out with a paper this summer talking about modifiable risk factors, things that you can do in midlife to help to stave off or prevent or delay onset of disease. There are also a number of places where we're looking at therapeutic targets that are really more related to blood flow or to inflammation. And the idea being, let's do everything we can, as Jack said, to prevent the onset of disease. Okay. But when those things may still break through, when Alzheimer's may still break through, what are the ways that we're going to do better detection and diagnosis, better management and treatment of disease to ensure that we live the healthiest life that we can for as long as we can?
What are some examples of that, like these better methods and treatments?
Well, I think right now we've got a couple of new treatments that are on the market that are related mostly to amyloid and amyloid clearance. There are some promising things on the horizon, as our previous speakers talked about with GLP-1s. And we're hopeful that there are other things in the pipeline. You can look at across all of the different companies that are involved. The Alzheimer's Association International Conference just happened in July. And that exhibit hall told you a lot about how many people are in the space developing biomarkers, developing diagnostics, and developing better treatments. There's something new on the market to help manage mood and behavior. These are actually quality of life treatments and interventions that are really important for people who are trying to keep loved ones home as long as possible, or to make sure that people's quality of life is as good as it can be. I also think it's a complex disease that has so many different contributors. And as Jack said, hypertension alone is 119 million Americans who are living with hypertension. And it is a risk factor. It is a contributor to Alzheimer's. Could we look at that Venn diagram and think a little bit more clearly about those who are at risk of Alzheimer's disease, folks who have known risk factors, and how do we develop a foothold in terms of interventions that helps to extend healthy and productive life and prevent some of the tremendous suffering that this disease in particular brings to families. We're excited that with both the national plan, the great groups that exist in the Alzheimer's space, there are some tremendous experts across the United States and across the globe who are thinking about Alzheimer's in critical ways, with collaboration, with thinking about the multifactorial disease in a new way, and in this era of, I think, hopeful progress that we've been making over the past 10 years, and really rapid progress in the last 5. Okay. We are hopeful that there will be additional interventions that deal with the different contributors to and causation pathways related to Alzheimer's disease. I hope folks consider being part of clinical trials and clinical investigations. Talk to your physicians, talk to your family members, talk to the experts that we have here. There are all sorts of ways to help reduce the burden of disease, and I think there's so much promise in terms of innovation right now. And I'm excited that we are thinking about heart and brain in the same breath finally, because these two, what's good for your heart is good for your brain. The association, and Rob Egge will be talking here in a minute, they've been working on these topics. I know George and Us Against Alzheimer's are working on things that relate to how do you think about heart health that will contribute to brain health. in really impactful ways. And it's just nice to be a part of a strong community that's dedicated to improving outcomes for the population that we all care about.
Well, that is incredibly encouraging. And as Mary noted, many of our experts will be here after the event. So if you have questions that I didn't get to, please feel free to come up to them. This is all the time we have right now. I could keep going, but I'm so glad you took time to join us. And I want to thank you again for sharing so much of your knowledge and insight with us.
Thank you.
Thank you, Gene. Appreciate it. Thanks you, everyone.
Mary?
Please welcome to the stage Axios senior policy reporter, Caitlin Owens.
Good morning, everyone. It's great to be here with you. As you just heard, I'm Caitlin Owens. I'm a senior reporter here at Axios, and I'm the author of our Future of Healthcare newsletter. For our next interview, please welcome to the stage Chief Public Policy Officer of the Alzheimer's Association, Robert Egge. Thank you so much for being here.
Great to be here.
And in classic Axios style, I want to start with the breaking news, which was coming from the Hill last night. There was a piece of legislation that passed the House. Why don't you tell us about it?
We're very excited, and it fits very well with this conversation, as a matter of fact, that last night the House took action and unanimously sent to the Senate the Bold Infrastructure for Alzheimer's Act. And that's important because it deals with public health approaches to all dementia, including risk reduction, which is very central to this conversation this morning.
And can you tell us a little bit more about that public health infrastructure that it's supporting?
Yeah, it's an interesting story because for so many years, rightly, all dementias were thought of primarily as an aging issue. And there had long been a very important, pivotal piece of work that was done by the CDC called the Healthy Brain Initiative. But its proportion to the scale of the problem that we face as a country was not proportionate at all. And so what this legislation does is it gives CDC the resources, not only for their work, but also for them to work with state and local communities to make sure that there's a comprehensive public health approach now to addressing Alzheimer's and other dementias through things like detection and risk reduction.
Awesome, and we're going to talk more about that, but let's go backwards a little bit. I'm going to spend a couple minutes on treatment, because as you and probably most of the audience knows, the big news in the Alzheimer's world the past few years has been the approval of anti-amyloid drugs. How has that launch gone, in your opinion, and what has demand been like?
Well, the launch has been encouraging, but it's been slow. So, you can measure this in two different ways. I measure this in part by the fact that I have loved ones right now that we don't know, might be candidates for this, and they might choose to take it, but right now it's not in reach for them. So that leads me to be very impatient about this. I wish they had options. So in that sense, it's going slow. On the other hand, if you look at what it takes to roll out a new class of drugs, especially in a condition like Alzheimer's that hasn't had effective treatments before, then we're seeing an encouraging upswing now in terms of access to these treatments.
And so a theme of my reporting for the past couple of years on these drugs is the question of whether the risks outweigh the benefits. What's your opinion on that? How do you think about that question?
Well, I think for one thing, it's going to be an individual's decision. And it's very consistent for one individual to decide that balance isn't right for me, and for another to say it is right for me. And that's what we ultimately want. There's also a scientific way to look at this as well. And that is on the basis of To this point, fundamentally, the phase 3 trial for this first drug that's available, Leqembi. And there we saw that indeed there are safety risks that have to be handled very carefully, and that it's legitimate to be concerned about those and to focus on them and to manage them well. On the other hand, we saw true meaningful effectiveness that really wasn't in doubt in terms of delaying the progression of Alzheimer's specifically.
And so an interesting question to me, I think, is what is the future of this class of drugs, right? And so I think there's some people that say they should be used for narrow patient populations. As we just discussed a little bit in our prior conversation, there's talk about giving them earlier as more of a preventative kind of treatment.
Right.
Can you kind of, do you fall on one side of the debate versus the other?
I do. I'm optimistic.
Okay.
But we
tell
need
us why.
science to really tell us what the ultimate answer is, right? And so, but I'll tell you why I feel that way.
Yes.
So the reason I'm optimistic is, first of all, we see the results we have so far. We're starting to see more and more data. So there's an open, legitimate question after an 18-month trial of any sort. What happens afterwards?
Right.
And there's been a lot of concern and speculation. What do we start to see? Well, we're starting to see results. We just had our largest science conference each year, where more results were released about the open label extension study for Leqembi. And I think those results look to be in line with an optimistic view, that you generally see an increasing separation, and that safety management is just like in the trials themselves fundamentally. So that's encouraging to me that we see that data accumulate. There's another thread, though, that I think leads me to some real optimism here that we see, but it's also a challenge. We see in both this first treatment and now the second that we have available today, Kisunla, which was approved just this summer by the FDA, that in both cases, the earlier you initiate treatment, the more effective it is. And our healthcare system isn't equipped for that challenge, but on the optimistic side, if we can be taking advantage of this opportunity to treat as early as a patient might wish to with their provider, then they're going to get better results. The data seems to indicate very strongly. And there's every reason to speculate, but it is speculation right now until we see trial results, that if you even go before symptoms begin, perhaps we'll see that same kind of effect starting even earlier.
How early are you thinking?
Oh, I don't know. I have to be careful here because my imagination.
But it is the question.
Yes. So, if you look at where it's being tested right now, let's just imagine that several years before the onset of symptoms, that we may see trial results that indicate that's warranted for some patients.
Now switching to the non-pharmaceutical side of treatment and prevention. This has been a big topic, and culturally there's been a lot of chatter about healthy aging. What are your policy priorities in this space?
Well, fundamentally, not to go too much back in time about the history of this, but our fundamental challenge for this condition over a scale of over a decade now has been to draw attention to it. And the fundamental reason is a chronic disease that's been growing over time. It's been a slow boil. There hasn't been an Alzheimer's crisis. Sometimes, if you think back in years, you'd have somebody like President Ronald Reagan who would announce his diagnosis, and that would feel like for a moment in time, grab attention. But it's not like when COVID or Zika virus or others command attention. And so we were kind of locked into a 1970s view of what Alzheimer's was and other dementias, their impact. So we've tried to create, in policy terms, a structure that overcomes that and focuses a conversation, because we think the facts speak for themselves in terms of the opportunity and the need to act quickly. So 2 bills, this is also very timely. One is the NAPA bill that's been referred to, the National Alzheimer's Project Act, which we spearheaded about 10 years ago in 2011 to create this necessary conversation, updated annually, about a national plan to address Alzheimer's and other dementias. That right now is, along with another bill called the Alzheimer's Accountability and Investment Act, are both, we heard this morning, set for the House to take up next week, with a big thanks to Johnson, Scalise, and Jeffries for that decision that they made together.
That's another piece of news for you. And what about outside of policy when we're talking about healthy aging? What are societal changes that could help with dementia prevention?
Well, it's both good and bad news, I think, that what we're seeing more and more from the science, and we have another study coming out very soon called the US Pointer Study that should be the best evidence yet for what works for all communities in the United States. So there's a heavy representation. This has been a challenge with different communities like African Americans and Hispanics in this study that will release its results. But already we see compelling evidence that what we should do to reduce the risk of cognitive decline is very similar than for other diseases. So the good news is there's not any new prescription here, in really fundamentally in terms of what you should do. You should exercise, protect your heart. You're also protecting your brain. Those things are true. The challenging part is we've known this for a long time, right? It's still hard to motivate any one of us to take these actions. So we have to be thinking as a country more and more for dementia and many other chronic diseases. How do we encourage people to do what we now know from science works?
Well, and there are plenty of structural barriers in place for wide swaths of the population. And that's something we'll talk about more in our next conversation. But those aside, what are the most impactful lifestyle choices people can make?
I like to keep it simple.
Okay.
And so I think one is to move, right? I'm on my 8th version probably of counting my steps and trying to be diligent about that. So that's important. And it's the evidence I see at science conferences that convinces me to do that. In terms of just controlling our health, in terms of obesity management, not smoking, those are important steps, getting good sleep. These are all things that we see strong, anything from glimmers to conclusive evidence that they will certainly help. And you can't go wrong if you do them. And a last one, which has really strong evidence behind it now, is controlling your blood pressure.
Interesting.
Yeah, we've seen that confirmed in rigorous trials.
Very interesting. And then what about caregiving? I want to bring that up because I know, as the previous speaker mentioned, there's a growing population of people with dementia. Caregiving in general is a big topic these days. What are your policy priorities in that space?
Well, one way just to sort of amplify how important this is we just did a sort of a rigorous survey on this, and large sample size, representative. We found that half of respondents said that they themselves had, and that was small, 3%, or a family member has, 47%, dementia currently in their family that they're dealing with. And so there are caregivers, people with the disease, but caregivers everywhere coping with this and other diseases as well. And so some of the encouraging work that's being done in this space at the federal level is approached from even a broader perspective than just dementia. And there's great work going on that front holistically, and we are strongly a part in favor of that because the solutions aren't necessarily disease specific, but some are. Knowing how to deal with dementia, what are the coping strategies, there's a lot to learn that can really help people out. And so 2 quick examples, one and just fundamentally is at the state level, where so much of this is settled. And so we have a high emphasis on state policy for this very reason, among others. A second one is very encouraging is that the Department of Health and Human Services just announced the guide model, it's referred to as. And part of that work of the guide model, it's in Medicare, fee for service, to create value-based reimbursement and a holistic approach that they're testing now for care for dementia. And part of that they recognize and are supporting is equipping caregivers along with navigators to be part of that work to make sure that people have the support they need with this really difficult condition.
Awesome. And is there anything on the Hill we should be looking out for?
Well, I would point back fundamentally to both NAPA, the bill I mentioned, because that is a structure in which caregiving is talked about among agencies along with other voices. And so that's reauthorization is going to be extremely important. And then the BOLD Act, equipping states and local counties to test and then promote these interventions is extremely important. So those 2 bills, I think, should be front and center for Congress.
And then with our final few minutes here, I like to end the interviews I do in my newsletter with a prediction. So I think I'll do that here. What is something that you think will be different about Alzheimer's in the next 5 to 10 years? And maybe not about the disease specifically, but about the way that we can either prevent or treat it.
I think the biggest change we're likely to face with Alzheimer's, and it won't necessarily apply, regrettably, in the same way to other dementias, we need to get there, are blood-based biomarker tests. I think at the pace they're going right now, and everybody's excited and surprised by the pace of movement, not there yet, towards clinical use. For people to be able to understand with a test like that confirmatory evidence right there in their blood, if they're dealing with Alzheimer's, is going to be a really big positive shock to our system. It's going to expose a lot of challenges. We do have a lot of adjustments to make, but that will be a fundamental societal change, I believe, that we've not seen before with this disease.
And walk us through what that would look like from a patient's perspective.
So here, I want to, see what clinicians end up saying. One thing that we're leading is developing rigorous guidelines with independent voices, leaders, to say what this should look like. But some things I think are pretty easy to predict and not too surprising. And that's, you will go into a clinician's office, your healthcare provider,
Okay.
and they'll recommend, if you meet certain criteria, which have to be defined, a battery of blood tests, right? This happens today.
Right.
This will be one of those tests, and it will lead to, depending on the results, conversations that need to happen as soon as possible, given the new treatments we have today. The sooner, the better.
And what are the main barriers to that happening?
I think the main barriers for that happening are, first of all, it just takes time to validate how these should be used, for clinicians to understand their use. They're so busy, they have so many things to think about, and to work into the stream and get reimbursement established and clear. Those are the steps that we need to see, but I bet they'll be substantially addressed in the coming 2 years.
Well, that is fascinating. It's also a good note to end on because we are out of time. Thank you for such a great conversation, Robert, and for joining us here today.
Great to be with you.
You as well.
Thank you.
All right, and joining us next, get ready for this title. Please give a warm welcome to the Deputy Assistant Secretary for Behavioral Health, Disability and Aging Policy at HHS's Office of the Assistant Secretary for Planning and Evaluation, Dr. Tisa Marie Sherry. Hi. Thank you for joining us. Thank you so much for joining us today.
Well, thank you for having me. It's a pleasure to be here. This topic is a huge priority for HHS under Secretary Becerra and for the Biden-Harris administration, so I'm privileged to be able to talk about the work we're doing.
Well, that tees us up well for our first question. How does the federal government think about its role in dementia prevention?
We view ourselves as having a critical role, but that also requires partnership with really a whole of society, state, local governments, public health departments, and also key actors in the private sector. Part of what I do at HHS with my team is to help oversee implementation of the National Alzheimer's Project Act.
Is that NAPA that Robert was just talking about?
Indeed,
awesome.
Yeah, that is NAPA. Several years ago, we added for the first time in NAPA's history since it was passed, a new goal. That was our 6th goal, to reduce the risk for dementia and accelerate action to support healthy aging. That goal has provided our framework for not just an HHS-wide, but really an all of federal government-wide approach to make sure that we are coordinating the work we do to take the accumulating evidence of risk factors for dementia and translate them into policy and public health changes. So we see our role as helping to pull together all of that evidence, help translate it into actual policy and public health changes, and engage our external partners to make sure that we can drive transformational change.
So over the past 4 years, what changes has the Biden administration made to those policy and public health approaches?
So one is the BOLD Public Health Centers of Excellence program. So that is run by our colleagues at the Centers for Disease Control and Prevention. Those grants have enabled us to provide additional resources to public health departments to really help support dementia risk reduction activities in a public health framework, so to really embed them in the work they're doing. Also to more effectively communicate and translate all of the new research that we are seeing about risk reduction to help inform the broader public about what all of this means and what you can actually do. Another example is in October of 2021, the Food and Drug Administration issued voluntary guidance to the food industry, encouraging them to voluntarily reduce sodium targets in a wide array of foods. Now, why does that matter? Well, hypertension is one of the most established risk factors for dementia. And by doing this, and we now have some preliminary data showing that about nearly 40%, we're seeing nearly 40% of targets hitting that goal, which is really great news. That's an example of how we have taken federal action to try to make it easier for the public to reduce their risk of dementia.
Right, and so just kind of from your position, it's you were the department and you. How would I want to say this? You're kind of the public spokesperson for translating all of this, right, and trying to understand this. So at a high level, what have you learned and what do we know? What's the most recent evidence about what works and what doesn't for dementia prevention?
So it's a terrific question, and I'm going to couch my answer a little bit because honestly it changes almost every day. I feel like almost every morning I wake up and I have a new Apple News alert on my phone about a new study identifying risk factors related to dementia. I think you'd heard earlier that this summer there was a new updated study published in The Lancet that presents what we know in the current state of evidence on risk factors. And there is a wide array, many of which are related to other chronic diseases that affect people in midlife. Hypertension is probably the risk factor for which we have the strongest established evidence base, but also importantly, diabetes, smoking, obesity, depression, hearing loss. We're seeing evidence really accumulate for that as well. In terms of what people can do, there is a lot of evidence that blood pressure reduction and control can meaningfully reduce the risk of mild cognitive impairment, which is a well-known precursor of dementia. Study published just in the last year showing that use of hearing aids in people with dementia risk factors can also reduce the risk of dementia. We're getting more and more information about actions that people can take, but what we think is really important is making sure that the public has accurate evidence, is able to make sense of all of the new information that is coming out. And so that has been also a key focus of our work.
Well, and that I was just about to ask you. Wellness culture has become a big deal in the past few years. I'm assuming that some information is better than others. How do you deal with bad or even just not so good information that comes out?
So that is a great question. It's absolutely true that not all studies are created equal. There are some that have stronger designs than others. And also in general, we don't change practice or guidance based on one single study. We look at the overall accumulation of evidence. We look at how strong a relationship is, how meaningful an impact, and we use that to guide decision making. I think this is an area where my colleagues at the Centers for Disease Control and the National Institutes of Health have really worked very hard to try to make sure that we are regularly and routinely assessing the rigor and the quality of this evidence, and then trying to share and disseminate that information with the public in ways that help us parse through what's really strong here, get the signal out of the noise, and help people understand what are some of the things that may be more impactful actions to take than others. One example of this is our colleagues at NIH have for some years sponsored a public health information campaign, Mind Your Risks, which is about the relationship between vascular health and cognitive health. Specifically, it has targeted Black men in midlife who are unfortunately at among the highest levels of risk for vascular disease precursors of cognitive impairment.
And so as we're talking, I'm picking up on there's so much overlap with just general keeping yourself healthy. That's easier for some people than others. Can you talk about how inequities come into this space?
I'm really glad you raised that because that has also been a key focus of our efforts here. I'm sure, and I'm sure many other people in this audience all wish that we ate healthier, that we had more time to exercise. There are a number of things that we'd love to be doing more of to help support our health, but let's be honest, it's challenging. We all lead very busy lives. And imagine how much more so if you're somebody who also has caregiving responsibilities, does not live in a community where you have access to a safe space to exercise, is working maybe multiple jobs in shifts that don't coincide with allowing you to have a routine sleep schedule, which we also know can contribute to the risk for dementia. So we recognize that it is not easy for everybody to make some of these changes. And so we believe it is important to move beyond just putting the information out there and instead really take a public health and public policy approach to create structural changes that make it easier to make these changes. One example of that is the FDA sodium guidance that I mentioned earlier. By doing that, by encouraging the food industry to reduce sodium levels in foods, that's one less thing that somebody with hypertension who is having to manage so many different things in order to keep their blood pressure under control has to worry about. I think that's just one example of the sort of policy and public health action that we believe is essential to make it easier for people to follow what we're learning from these studies.
I'd love for you to expound on that because I think we've talked a lot about what individuals can do to reduce their risk. But you're sitting from the federal government, and ultimately changing structures is the federal government's job. So can you talk a little bit more about what some of those efforts have looked like?
Absolutely. So BOLD is one way that we have tried to do that, and critically, a lot of the action that needs to happen to change these happens with our partners outside the federal government. And I think you've heard some of our speakers earlier mention that we as federal government do play a critical role. It's not something, unfortunately, we can do on our own. I wish it was, but we really need partnership from state, local governments, from employers. Think of what % of time people spend at their jobs and how significant an impact that has on their health. So a lot of the work that we have done by supporting, investing in local public health departments, providing them with the latest up-to-date information, creating communities of practice really so that different localities can share best practices about what works to create age-friendly communities is where I think that we can have a real role. Draw attention to things, signal the importance, signal the priority, and then bring all the right people to the table to really help convene and foster that whole of society response.
And I want to ask you a similar question as Robert talked about, but caregiving. When we're looking at the growing burden of dementia over the next few decades, what do you think is most important policy-wise to be done that we should do to prepare for that?
So there are a number of actions that we have taken at HHS and also more broadly under the Biden-Harris administration, recognizing the critical importance of caregiving and the increasing needs for caregiving support in the coming years for dementia, but also more broadly for older adults without dementia, for people with disabilities. A number of those actions are highlighted in the administration's executive order on the care economy, which really has driven a whole of federal government response to trying to support the paid care workforce, but also our critical unpaid family caregivers who are really the backbone of our care system for people with Alzheimer's disease and related dementias. One example of this is the RAISE National Family Caregiving Strategy, which is coordinated by our colleagues at the Administration for Community Living. And then you also heard recently about the Center for Medicare and Medicaid Innovations guide model, which is really a path-breaking new model to try to not only strengthen comprehensive medical care and care coordination for people with dementia, but also support their families and caregivers. For the first time, there is a respite benefit for caregivers that is included as part of that model to recognize and help address some of the additional supports that people who are doing that really essential vital work need. The level of interest that we have seen in participating in that model has been unprecedented and also just really encouraging to see how much our external partners in the healthcare system really want to take advantage of this opportunity to innovate and address the needs of caregivers. So we're really encouraged by what we've seen.
Awesome. And I want to wrap up by asking you to switch hats for a second. and put on your doctor hat. What advice, given that, with the disclaimer, you are not our doctor, what advice would you give the audience to age healthily?
So a lot of the evidence that we have about what helps people age healthily, really gets down to common factors that we see for a number of chronic diseases. So chronic disease management is a key thing for people who have hypertension, for people who have diabetes, for people who have obesity. What we're generally seeing is that being able to manage those conditions helps overall brain health. It shouldn't be surprising that the brain's an organ like any other, and the things that we do and that we have learned work well for addressing other conditions and helping other organs be healthy also helps with the brain. But we also think that some of the emerging evidence on social connection is also very interesting. It's something that we are following very closely. And finally, some of the emerging evidence around how changes in a lot of age-related changes in our sensory functions, hearing, vision, are also things that we're paying close attention to, and are a reminder to us that some of those things that may often be overlooked in healthcare settings or that may not come to the attention of healthcare providers are also critical things for us as healthcare providers to be attentive to, and then as us as people, but also advocates for the people in our family to make sure that we're raising.
Well, that's all the time we have for today. Thank you so much for joining us, Dr. Sherry.
Thank you.
And to our audience, be sure to subscribe to me and Tina's newsletters, which are The Future of Healthcare and Vitals. You can do that at Axios.com. Thanks again for joining us on this rainy morning, and have a great rest of your day.